Hello, my name is Dr. Jenifer Lightdale. I'm one of the associate editors for gastrointestinal endoscopy, and it really is a great pleasure to be here with Dr. Fabian Emura. And you're talking on behalf of yourself and Dr. Todd Barron and Ian Gralnick, and both of whom I know well. And you're going to tell us about some thinking outside the box. And the title of your paper was actually The Pharynx, Examination of an Area Too Often Ignored During Upper Endoscopy. I was just chatting a bit with you, but tell us again how you started to think about this and what you realized.
Thank you. What we believe is that pharynx is the very first part of the GI tract. And if we have such a powerful tool in our hands, which is endoscope, I think it's a good idea to take a look of the pharynx. Actually, there are many papers coming reporting early diagnosis in the pharynx, cancer diagnosis. Mm-hmm. And actually also many papers coming doing endoscopic treatment by EMR or ESD in the pharynx.
Yeah, actually you gave some statistics in the paper that were kind of startling. You said the incidence of this oral and nasopharyngeal cancers is at 30,000 incident cases in the U.S. annually, and you said 8,000 deaths. Is that right?
Exactly, that's true. The point is that there are many people dying of oropharyngeal cancer, and nobody, or at least not many people, is doing something good for them. Mm-hmm. I think, we think, Todd and Ian and I, that we can play an important role being endoscopists and taking time to examine the pharynx.
So and I think you put it so well in the paper, you say, look, you're in there anyway, right? You have to go through the pharynx in order to get to the esophagus. Exactly. Having said that, you say, and it was a bit of a provocative statement, you say it may be the responsibility of the gastroenterologist to look at the pharynx. Can you tell me a little bit about what you think the evidence is that it's our responsibility, or how we're going to meet that responsibility?
Actually, we believe that pharynx is a land without ownership at the present time. For example, otorhinolaryngologists, they don't look at carefully the hypopharynx. And head and neck surgeons, they do advanced surgery for advanced cases. So nobody is taking a look of the pharynx, actually. And there are many people dying. Mm-hmm. If we are passing by every time, in every upper GI procedure through the pharynx, I think as it is important to take a look. And it's very easy, actually. We need training, probably. We need to include pharynx examination probably in our endoscopy or gastroenterology curricula. Mm-hmm. And we will see, but probably that's going to be a thing that we're going to do in the future. And finally, the benefit will be for patients.
Are there patients who are particularly at risk?
Yes, there is a high-risk patients.
Okay.
That group is composed by men, smokers, heavy drinkers, and patients that they do not take a important amount of fruits and vegetables.
Okay, fruits and vegetables. That's tricky because my kids, I feel like I'm already not teaching them very well. But so it's almost like you could ask those questions ahead of time and say, okay, this is a patient that I'll take at some time, and perhaps I'll see something nobody else has really had that opportunity to see. Yeah.
There are two groups, big groups. I'm talking about high risk. Mm-hmm. People who is above 90%. I think that there is a cutoff. And we published in our paper the health risk appraiser model, which was designed by a Japanese group. So based on the amount of fruits and vegetables that the patient have, and based on if it's a smoker or not, or if heavy drinker or not, they gives you a score. Okay. And that score finally gives a percentage and what the people is located. And if it's above 90%, we must to do pharynx examination because that patient is a high-risk patient. So probably, I mean, I think things are going to change. We're going to do probably health risk appraisal examinations, and probably we will find more pharynx cancer and try to reduce mortality.
And of course the goal would be to find it early when you actually can do something about it. Is there something we can do about it endoscopically?
Yes, of course. Early lesions are well treated by EMR. Using, for example, EMR cap. It's not difficult, but probably the patient needs general anesthesia and endotracheal intubation. And also there are many reports talking about ESD with a nice resection, complete in block. And that gives curability, which is very important, and we are happy if we have a patient that is cured. We celebrate that.
Sure. No, that sounds terrific, and it sounds like you're saying there's an opportunity here and we should be taking it as gastroenterologists, and of course it will benefit patients, so that's terrific. Thanks very much.
Thank you very much.
Thank you.